This research was done to compare the efficacy and the safety and outcome of ablation of paroxysmal atrial fibrillation. We compared between the 3D CAR2 system and the cryoballoon ablation. This study was done at the time of introduction of the cryoballoon ablation here in Ain Shams. So we had our experience, beginning experience in the cryoablation. This was about 4 years ago when we started this study. Definitely, our experience in cryoablation 4 or 5 years ago is definitely different than our experience now, and also in the CAR2 mapping. We all know that the catheter-based treatment for paroxysmal atrial fibrillation is an effective method for controlling symptomatic patients not responding to medical therapy. And the standard care is anatomical pulmonary vein isolation for dealing with cases of atrial fibrillation. And the balloon-based technology inducing isolation by tissue freezing has been developed and showed promising results. And many studies showed that the cryoballoon radiofrequency ablation is showed non-inferiority to other methods like 3D mapping or CAR2 mapping. So we did our experience and we did our search. We aimed in our study to compare cryoballoon ablation with radiofrequency ablation of pulmonary veins in patients with paroxysmal atrial fibrillation, and we compared its safety, efficacy, and long-term follow-up. Our study included 113 patients referred either in the cardiology department at Ain Shams University and in Royal Prompton Hospital. This was conducted through our candidate, Dr. Omar Hatem, who was there. He worked there in Royal Prompton Hospital for about 6 months, conducting AF ablation cases there, and we conducted our cases here in Ain Shams University. We did 44 patients with cryoballoon ablation, 20 patients in Ain Shams University, and 24 patients in Royal Prompton Hospital. Regarding radiofrequency ablation using the CAR2, we did 24 patients, and there were 45 patients there in Royal Prompton Hospital. So collectively, 44 patients cryoballoon and 69 patients with radiofrequency ablation. Of course, our inclusion criteria included patients who were symptomatic, failed to respond to medical treatment, either class 1 or class 3, with documented AF with 12-lead ECG or Holter monitoring. We excluded all patients with having intracardiac thrombosis, resistant or AF. They were not included in our study. Any patient with redo, with recurrence after previous ablation, we didn't include him in our study. Patients with valve in mitral aortic position, any patient with pulmonary pathway, of course, any patient having acute systemic infection was not included in our study. All patients were subjected to detailed history taking and physical examination, ECG and routine labs. All the patients had transthoracic echocardiography. We measured the left atrial diameter, anteroposterior diameter, the left ventricular ejection fraction, the valvular function. We did in most cases multi-size CT to detect the anatomy of the pulmonary veins, and also before the procedure we did TE to exclude left atrial thrombi in the left atrial appendage. The procedure was either to the RF energy or to the cryo energy, and pulmonary vein isolation was performed, and acute success was determined by the proof of the presence of entrance and exit block, and the procedure anticoagulation was maintained with maintaining the activated clotting time more than 300 seconds. In the cryoballoon AF ablation, we used the second generation balloon, 28 millimeter cryoballoon. We used contrast. We used one transeptal puncture with a 15 French deflectable catheter, sheath catheter, which was used supplied by Medtronic. We used to start with the left superior pulmonary vein first, then the left inferior. لا أول تمام. We used to start with the left veins first. Start with the left superior, then the left inferior. We always inject contrast to make sure that the balloon is totally occluding the ostium, or totally occluding the vein. And then we shift to the right veins. We start with the right inferior, then leave the right superior pulmonary vein to be the last vein, as this is the vein which is with the most possibility of inducing phrenic nerve palsy, so we leave it to the end. And of course, it was after finishing the therapy, and if you can see the therapy, when we reach to minus 40 or maybe minus 50. Freezing, yes. But this photo was taken after we finished the yes. And this is real-time pulmonary vein potential, and here we can see the pulmonary vein potentials, and when applying the energy, there is starting to see some delay in the pulmonary vein potential till it disappears completely, and this was achieved in all the pulmonary veins in all our cases. The cases which we done with the radio frequency ablation, we used the Carter 3 system, general anesthesia, 2 transseptal punctures. Some cases we used, in some cases, the Thermocool, and we used the contact force sensing, the Smarttouch catheter in other cases. In all our cases, we were strict to the rule of the AF recurrence, which is the symptomatic or asymptomatic atrial arrhythmia that lasts more than 30 seconds, excluding the first 3 months of the blanking period. And we did regular follow-up of the patients at 3, 6, and 12 months. We compared the cryo group to the RF group, and we compared the Thermocool to the Smarttouch, and we studied the predictors of 1 year recurrence. Regarding the 2 groups of the cryoballoon and the radio frequency, the baseline characteristics were nearly the same. There was no big difference except for the AF duration, which was more AF duration before the procedure, which was more in the radio frequency group. And regarding the echocardiography data, we had bigger left atrial size in the radio frequency group, but similar ejection fraction. The procedural time was definitely in the radio frequency group. It was is much more longer in the radio frequency group because the cryoballoon, we all know that it's more simpler, and maybe we had more time in making the map and making the pulmonary veins and drawing the map itself. Regarding the complications, there was no big difference between the 2 groups. Maybe you had 1 case of cardiac tamponade in a cryoballoon group, which was definitely related to the transseptal puncture, so it shows no difference between the 2 procedures. We had 1 case of long-term phrenic nerve paralysis. Otherwise, we had in the radio frequency group, we had 1 case of minor cardiac effusion. Regarding the clinical outcome, after 1 year of follow-up of the patient, the AF in the blanking period at 3 months was the recurrence was 18% in the cryoballoon group and 23% in the RF group, and the recurrence at 6 months and 12 months was a bit better in the cryoballoon group. At 12 months, recurrence was 27% in the cryoballoon group and 30% in the RF group. And this is the AF-free survival curve, which showed a bit better cryo group, a bit better recurrences, or less patients with recurrence in the cryo group than in the RF group. Regarding the comparison between the Thermocool and the contact force Smarttouch catheters, yes, most of the patients were similar in both groups, except for the age, which was more older patients in the group of the Smarttouch catheter. Maybe we had more female patients, and we had less, regarding the Smarttouch, we had less AF duration. The patients with more AF duration were used. We used Thermocool catheter in these patients. Regarding the echocardiographic data, it was similar. The procedural time was much more less in the Smarttouch group, and the fluoroscopy time was also less, because of course when we use the Smarttouch we are more confident and more comfortable with our catheter. We are more safe, we feel more safe, so we don't press fluoroscopy as much as when we use the Thermocool, when we're not seeing the contact exactly. And the clinical outcome, it was comparable, but the Smarttouch showed less recurrence of the patients after 1 year. The AF-free survival was better in the Smarttouch than in the Thermocool. And we studied the predictors of the recurrence of AF after 1 year, and we found that the obesity has a factor, but maybe it's the body mass index was more in the patients with the recurrence. The length of stay after the procedure, which was related with any complications that occurred with the patient. The presence of diabetes was a bit higher in patients who had recurrence, and of course the presence of AF during the blanking period was associated with more patients recurrence after that, after 1 year in our follow-up. So our conclusion was that cryoballoon induced pulmonary vein isolation is an effective method for ablation of paroxysmal atrial fibrillation. It is safe, shorter procedural time. In the subgroup analysis, contact force catheter was associated with definitely less procedural and fluoroscopy duration, with tendency towards less recurrence. The occurrence of atrial fibrillation in the first 3 months after ablation, presence of diabetes mellitus, the higher body mass index were associated with atrial fibrillation recurrence after 1 year. In patients with symptomatic paroxysmal atrial fibrillation who are not responding to medical treatment, we recommend that cryoballoon ablation is definitely a feasible alternative to the radiofrequency ablation using the 3D mapping. And of course the contact force mapping is better, less time, less radiation exposure, and risk factor management in patients with atrial fibrillation, like diabetes, like obesity, is an important factor for prevention of AF recurrence after the AF ablation. Thank you very much.